Good evening. Welcome to the Nelson Talk tonight. Thank you for joining us. This is the final talk this fall in the Dr. Bruce J. Nelson Distinguished Speakers Series. I'm Jeff Groves, Dean of the Faculty and Professor of Literature at Harvey Mudd College. Our Nelson Speaker Series theme this year is Now, Social Justice and STEM. And we have enjoyed this fall several stimulating lectures and performances exploring contemporary issues of social justice and considering how we might incorporate social justice work both in our daily practice and in our long-range goals. Tonight we conclude this conversation with Dayna Bowen Matthew, an author and professor of law at the University of Colorado Law School and the Colorado School of Public Health. Now, before my colleague Dagan Karp further introduces Dayna, I'd like to acknowledge the generosity of the family of the late Bruce J. Nelson, class of 1974, for establishing this educational series to honor Bruce's memory. Bruce died unexpectedly in 1999, though not before having a tremendous impact on the many people whose lives he touched as an unconventional, eclectic, and irrepressible free spirit. He graduated from Harvey Mudd as an independent program of studies major and later earned his master's in computer science from Stanford and his PhD in computer science from Carnegie Mellon. At the time of his death, he was the chief science officer at Cisco Systems. We are honored and grateful to the Nelson family for the opportunity we have each fall to host exceptional speakers who are at the forefront of their respective fields. I also want to offer thanks to the Nelson Series committee members for planning this year's successful series and bringing tonight's speaker to campus. Faculty and staff members Sharon Gerbode, Dagan Karp, Colleen Lewis, Sumi Pendakur, and Beth Kruszkowski, as well as students Ramonda Giddings and Lisa Geller. It's now my pleasure to welcome Dagan Karp to the podium to introduce Dayna.
Thanks, everyone. I'm Dagan Karp, Associate Dean for Diversity, Associate Chair of the Math Department, Associate Professor of Mathematics. And it's my sincere pleasure to introduce Dayna Bowen Matthew. For students, I hope you'll find her an inspiration, and for faculty, prepare to feel bad about your comparably meager professional accomplishments. Professor Matthew received her BA from Harvard, then law degree from Virginia, and she, as a lifelong learner, had first a career in law and then came back to receive a PhD in health and behavioral sciences from the University of Colorado, where she's now a full professor. Currently, Professor Matthew's on a 2-year leave working on national health policy issues in Washington, D.C. During 2015, she was a senior advisor to the director of the EPA's Office of Civil Rights. That's right, the Environmental Protection Agency has an Office of Civil Rights. In 2015-2016, she was a Robert Wood Johnson Health Policy Fellow, serving on health policy team for Senator Debbie Stabenow of Michigan. We'll hear more about that in a few minutes, I believe. She's currently a research fellow at the Brookings Institution and the Congressional Black Caucus Foundation. Professor Matthew has also been a faculty member at the University of Colorado Center for Bioethics and Humanities since 2004. From 2004 to 2011, she served as the law school's Associate Dean of Academic Affairs. That's what Prof. Laurie Bassman does here. And then as the law school's vice dean. On top of directing the law school's health law and public policy program, she teaches constitutional law, civil procedure, and a ton of other health public policy law courses. One of them, which seems really awesome to me, is an interdisciplinary practicum titled Poverty, Health, and Law that embeds the law, public health, and medical students in health clinics to collaborate in addressing low-income patients' social needs. It's super awesome to me. Professor Matthew's primary research interests are in health equity and integrated healthcare delivery, with an emphasis on delivering alternative payment models to address social determinants. These are not determinants of matrices from Math 40. These are people's characteristics that determine their health, right? So this is something important and interesting that we'll delve into. Knowing things about your social status determines health outcomes. Unfortunately, just the existence of social detriments, I think, should give us pause. And with our president-elect and the potential discussion of repealing Obamacare, this seems especially important to discuss nowadays. Prof. Matthew co-founded the Colorado Health Equity Project, CHEP, to form medical legal partnerships throughout Colorado serving low-income communities. CHEP provides direct legal representation to patients whose health is adversely affected by legal problems related to the social determinants of health. CHEP also trains and provides trains providers and develops policy strategies to improve public health of low-income populations. Currently, Professor Matthew is the principal investigator on a study to evaluate the impact of medical legal partnerships on children's health. She's also recently released a book titled Just Medicine, A Cure for Racial Inequality in American Healthcare. Please join me in giving a warm mud welcome to Professor Dayna Matthew.
Thank you, Dagan. I'm on, right? Okay, so I have to just do one modification. There's a small matter of my defense between me and my PhD right now, and it's scheduled, and I am intimidated. You're going to hear that I love to talk, and this is going to be lots of fun for me, but I still have the defense to go. So let me make sure I can do this. I want to talk about implicit bias. How many of you know about it already? Implicit bias, something you're familiar with? Now, a lot of hands went up. I'm going to play a short clip from the vice presidential debate where implicit bias was discussed, just to point out that we may know about it, but not know about it, right? So before I do, I want to start with a story. It's a personal story. When I was a college student like you, I was a sprinter. But I can't sprint anymore. And so I took up long distance running, and I ran the New York Marathon on Sunday last, and I finished. And I will not tell you my time, but I did finish. Thank you very much. And in order to train, I had to take a Lyft cab every Saturday morning to a meetup point from my running group. It was about 8 minutes away from where I live. 8 minutes is important to the story, so I'll say it again. It was 8 minutes away from where I live. On the Saturday morning that we had one of our long runs, I was very nervous. 20 miles is a lot for a sprinter. Everything I used to do in college was over in 60 seconds, right? So this was something that was making me very, very nervous. I called the Lyft. And as you know, the app gives you the opportunity to put your destination in, and it puts a picture of you up. My picture is fuzzy because it's fuzzy. So my Lyft driver appeared. I had run around to the Giant, gotten my fuel, which is a runner's name for a banana, right? So I'd gotten my fuel, and I came up behind him, jumped in the car, sat down. I'm like, okay, let's go, because I got to run 20 miles, and I got to get there. And he looked at me, and he goes, oh, you're going to Virginia. I've been driving all night. I can't go to Virginia. And I said, but actually, you're going to go to Virginia. And he said, I'm not going to Virginia. Get out of my cab. And I got angry. And I folded my arms and I said, you are taking me to Virginia. It is 8 minutes away, and then you can sleep, but you're taking me to Virginia. He turned around and canceled the ride with me in his car, locked the door, and started driving away. So now I'm not only angry, but I am petrified. And so I banged the door and I said, let me out of your cab. And he stopped and turned around. I couldn't make this up, and looked at me and said, do you want to go home with me? And I said, I mostly want out of your cab. I got out, and so I've gone from angry to petrified to powerless. And so I get out of the cab, and I fix my powerlessness by doing the most irrational thing I could imagine. I walked around all 4 of his doors, and I opened them. I was shaking. I was angry. I couldn't think of anything to do. And I'm telling you this story because I think he did that because I'm a black woman. But I don't know it, because he didn't say, get out of my car, you N-word. But I felt like it was an assault on who I am as an African American woman. So it wasn't explicitly stated, it wasn't explicit bias, right? But here's the rest of the story. That happened on Saturday, did my run. I usually feel great after my run. I didn't feel great. Sunday, I didn't feel great. I couldn't get my equilibrium back. So Monday, finally, I'm in another cab, getting ready to go to a meeting at 8, and I said to the woman, who's a Lyft driver, is there anybody I can report this to? And she gave me the number. It was the emergency number. I call the emergency number. The guy answers and he says to me, what's your emergency? I said, I think my emergency is that I was racially discriminated against. He had a Southern accent, and here's what he said. He said, that is an emergency. I'll sit here all day and listen to you. You don't have to get off of this phone if you don't want to. Nobody should have to live through that. Tell me all about it. I broke down and cried right there in the street. I simply broke down and cried right there in the street. Why am I telling you this? Because even if it wasn't explicit bias, it was implicit bias, and it hurt me. It hurt me so deeply that I didn't even know I was carrying it until somebody said, tell me all about it. So what I want to do tonight is tell you all about implicit bias, how it differs from explicit bias, but how it hurts as badly, and perhaps worse than explicit bias. I then want to tell you the evidence from social science about its impact in healthcare particularly, but also beyond healthcare, because implicit bias has a structural, a systemic, and a very far-reaching harm that I'd like to bring to your attention and hopefully get you to consider. Lastly, or second to last, I'd like to talk about remedies for implicit bias. What I can do, what you can do, and then hopefully some ideas about what institutions can do, and then we'll take your questions. So that's my agenda for the time that we're together. What really is implicit bias, right? Somebody once said to me very recently when I introduced this talk, implicit bias is just a very fancy way for saying racism, right? And I am going to challenge you to challenge me if you end up disagreeing with me that implicit bias is different from but informed by racism, right? And the reason I think the difference is very important is because the solutions are different. The harms are not different. The feelings that they stir up are not different. The sources are different, and we can talk about those differences, but certainly the solutions are different. So I'm not sure how to do, I think I can do this way. I'm going to show you a couple of things that I hope convince you, maybe just one or two things, that implicit bias happens when you don't think it's happening. I am not sure I'm going to be able to do a hyperlink. Do you think I can? No clue. Oh, I'd have to exit the slideshow? I'm going to save it for the vice president clip. I'm going to not exit the slideshow. Here are some examples, though, of videos. I'll leave these and somebody can post them, of how our mind works in ways that we don't intend it to work, right? Things that we are looking for will distract us from things that are happening that we won't see. Assumptions that are important to us from our experience will color what we see in a present circumstance, right? And so these three videos are just experiments that people have done. One of them is very familiar to you. I'm sure you've seen the invisible gorilla, right? The gorilla illusion. Well, this is a twist on that one where the curtain changes and a lot of thing changes. So you get the idea that to be human is to have implicit biases, right? So implicit biases affect everyone, and how they're generated is environmentally, right? So the music that we hear, the experiences, the Lyft story that I've just told you, right? That will color my biases when I next encounter someone who looks like the Lyft driver, who I feel discriminated against me. all of the experiences that I've had, the music that I've heard, the political environment that we're in, all of this creates social knowledge that we store involuntarily, right? We store it in a place that is accessible only by association, but automatically, right? It doesn't require intention. It doesn't require any deliberate activity on our part. We have social knowledge from all of the experiences that we have had, and they are retrieved and accessed, and they form perceptions and form biases that, and here's the research that we're going to talk about, that actually override our explicit preferences, right? So I am an egalitarian. I am even a progressive. I am a fair-minded, equal-thinking person. Those are my explicit preferences. That is how I would like to behave and be perceived. However, the stored knowledge about people groups that is retrieved involuntarily forms perceptions that will more powerfully influence my conduct, my judgments, and my communication than my perceptions, than my explicit preferences. Now, when you think about it, I've already said that implicit biases are something that we are all subject to. And it's because we need them to live. In other words, you have to have implicit biases to execute your life safely. Think about it. There are positive implicit biases, and there are negative implicit biases. Each can be used positively, and each can be used negatively. So let me give you an example. This quadrant shows, this 2x2 shows, right, that I can have a constructive use of a negative bias. I think I'm off again, but I still have a very loud voice, don't I? I have a bias against getting hit by a car, right? I don't want to get hit by a car, and so I make assumptions. I use heuristics to remind myself that a speeding car at a certain distance presents a threat to me. And I constructively use a negative bias, right? The fear of getting hit by a car. I don't intentionally have to think about it when I walk across the street. I automatically respond in order to keep myself safe, right? So organizing information, lots of information, in ways that allow us to shortcut deliberate decisions is a way that we execute our lives. Everybody does it. Everybody needs it. We need it to live. But we're concerned about implicit biases that have a negative effect, right? We're concerned about negative biases that are racial. So during the vice presidential debate, Vice President-elect Mike Pence and Tim Kaine were talking about implicit bias briefly, right? What I want you to concentrate on when we see this clip is the agony on their faces. They are uncomfortable. They are talking about race. They're not just talking about implicit bias that gets you across the street safely, right? They're not just talking about implicit bias that I've sort of said is ubiquitous, that everybody has. They're talking about implicit racial bias, and it makes them uncomfortable. Not only do they get it wrong, but they're uncomfortable. So let's just look really briefly, maybe, or maybe not. Okay. Really and truly, I can just tell them about it. Okay. All right. Now I feel like the clip better be really good, right? So I'm going to play a very short part of it. Mike Pence is going to say something that's just wrong about implicit bias. And I'm going to correct him later. Tim Kaine is going to try and get it right, but he's so uncomfortable that he can't get it all out, right? And the reason is because now we're not just talking about implicit bias, we're talking about implicit racial bias, extra charge, right? Why is it extra charge? Because we're always worried that the implicit racial bias accusation means you're a racist, right? We're always worried about that. And so we avoid the conversation. We're not going to talk about it because nobody wants to be called a racist. Nobody's going to listen to you once you call them a racist, right? And I know I'm not a racist, so you must not be talking about me if you're talking about implicit racial bias and what I do, right? So let's just, yay. Yay, okay, there we got it, right? This is going to give us permission to talk about race, okay? That's the real reason we need this clip.
But they also hear the bad mouthing that comes from people that seize upon tragedy in the wake of police action shootings as a reason to use a broad brush to accuse law enforcement of implicit bias or institutional racism, and that really has got to stop. I mean, when an African-American police officer in Charlotte named Brentley Vinson, an all-star football player who went to Liberty University here in the state, came home, followed his dad into law enforcement, joined the force in Charlotte in 2014, was involved in a police action shooting that claimed the life of Keith Lamont Scott. It was a tragedy. I mean, we mourn with those who mourn. We grieve with those who grieve. We're saddened at the loss of life. But Hillary Clinton actually referred to that moment as an example of implicit bias in the police force, where she used, when she was asked in the debate a week ago whether there was implicit bias in law enforcement, her only answer was that there's implicit bias in everyone in the United States. I just think what we ought to do is we ought to stop seizing on these moments of tragedy. We ought to assure the public that we'll have a full and complete and transparent investigation whenever there's a loss of life because of police action. But Senator, please, enough of this seeking every opportunity to demean law enforcement broadly by making the accusation of implicit bias every time tragedy occurs.
Elaine, people shouldn't be afraid to bring up issues of bias in law enforcement. And if you're afraid to have
I'm not afraid to bring that up.
If you're afraid to have the discussion, you'll never solve it. And so here's an example, heartbreaking. We would agree this is a heartbreaking example.
We're going to go through another heartbreaking example.
The guy Philando Castile who was killed.
Right. So here's my problem. We can't talk about it. If we can't talk about it, we can't solve it. And if we're going to talk about it, let's talk about it correctly. I want to do it from this slideshow. Thank you. Play from current slide. Right. Okay. Implicit bias is not the same as racism. Doesn't get you off the hook, though, because it is as pernicious, it is as violent as racism is, but it is not racism. We don't have to be afraid to have a conversation about the effect of what our automatic preferences do to people, especially in this talk on healthcare, or in police settings, or in courts, or in schools, or anywhere, right? We don't have to be afraid of that conversation. Let's talk about what implicit bias actually does, what the impact of implicit bias is, and why it's so important for us to not just confuse it with racism, but definitely acknowledge that its impact is similar. So the first takeaway message I'd like you to have is that we all have implicit race and ethnicity biases that are not the same as racism, but let's look at what they are and what they do. Let's look at the impact of what implicit bias does do. I'm going to use one example in healthcare: infant mortality. So around the nation, as in Colorado, this example is from Colorado, the infant mortality rate for African Americans is about twice that of whites, right? That's true in about every state in our country, right? It's tragically true and unique because in most disparities, if we control for income and education, we eliminate the disparity. That is not true with respect to infant mortality. So here again, Colorado's numbers. Women who are African American and middle class, that is, have incomes between $50,000 and $75,000 a year, still experience or suffer rates of infant mortality almost double that of women who are below the poverty line and white. So controlling for income does not change the outcome. Moreover, controlling for education does not change the outcome. So African American women who have a college education have approximately twice the number of their infants die in the first year per 1,000 as white women who do not have an 8th grade education, right? And so the point of showing you the infant mortality disparities is to just highlight the fact that race qua race matters. Not race because it overlaps with socioeconomic status, all right? Or not race because it overlaps with educational differences, but race in its own right has a driver effect, has its own impact on health disparities. Now, I used infant mortality, but I could do it for lots and lots of disparities that you guys are familiar with. But the point I want you to take away now is that we have to talk about the kinds of discrimination, the kinds of impacts that happen to health outcomes because of race, and only race, right? Or ethnicity as well, right? So all of the data that tells us that all the leading causes of death, all the quality treatments for those leading causes of death are disparately, unequally, inequitably distributed by race and ethnicity was gathered in this report in 2003. And the report cataloged hundreds and hundreds, actually 600 studies. And since 2003, the studies have been replicated and they are copious. So we know that disparities exist, both in health and in health care, that is in health outcomes and in the health treatment. We know that they are very clearly documented, right? These inequities, let me just define disparities. These inequities are not clinically driven, right? They're not clinically justifiable. These are differences in outcomes and treatment that are preventable and avoidable and unjustifiable. That's how we define disparities or inequities in health and healthcare, right? So what we know from the Institute of Medicine, now the National Academy of Medicine, is that part of the causal relationship between these disparities and bias comes from physicians, comes from providers, but we don't quite understand the mechanisms, right? So the research question that my book set out to answer is, what are the mechanisms? How does this happen? What do we know about it? Well, there is a fair amount of research, it turns out, that connects implicit bias in healthcare and unequal outcomes that we call disparities. I'm going to talk about 3 categories of studies. There are several others, but this will whet your appetite, I hope, and give you an idea of the research that's available. Anybody familiar with this picture? So the implicit association test is familiar to you. I won't spend a lot of time on it. I'll just tell you that it provides a way for us to measure the extent of an implicit bias. Now, it's important to know that there is a small but outspoken critical minority that suggests that what we're measuring with respect to the IAT is not bias per se, but implicit associations, right? So there is some controversy, and we can spend some time on that if it's of interest to you in the question and answer part of the program. But I will say that generally, this is a test that's validated as a way to measure the extent of pro-white or anti-black and pro-white or anti-Latino biases through these tests, which you guys are familiar with, that require a quick response to associate words with picture. And what we find from these tests, aggregating the results of the tests that have been taken by some million participants now electronically, is that the majority, indeed the vast majority of Americans, when you add those who have a strong automatic preference, a moderate automatic preference, and a slight automatic preference for whites, most Americans, over 70%, prefer whites to blacks implicitly, right? Similarly with the paired test that looks at the relationship or the association between whites and Latinos. Pro-white anti-Black, pro-white, anti-Latino, and that is an implicit bias, not a racist, right? That's an implicit bias, not a measure of your racism, okay? So, in fact, let me go back and just get warm and fuzzy with you. I'm on this chart also, right? If you haven't taken this chart, if you haven't taken this test, you will, I think, find it very enlightening to go ahead on to projectimplicit.com, and you can take it for race, you can take it for your biases against people based on their weight, you can take it on biases on political parties, you can take it based on biases with respect to gender. But I have taken it, and I figure in one of those places too. If you're nice to me during the question and answer, I'll tell you where I am also. So all of us have them. But takeaway message number 2 is that race and ethnicity biases are neither good nor bad per se in their own right. They just are, right? They come from our environment, as I spoke of earlier. They inform us unintentionally, and we have them, right? So what do? Alexander Green is the first study that I want to share with you. This is a study about the relationship between implicit bias and the impact that it has on physicians' treatment decisions. It's an important study because it showed us using, and I'll just very quickly go through the study design, using a series of computerized vignettes, right? Stories on computers where patients were given, actually actors were given a script which described their complaints as they presented in an emergency room, and those complaints were the same for every actor, who was only different by race and nothing else, right? They were even dressed the same in the computerized vignettes, right? So 287 physicians watched these vignettes and then did 2 things. Actually, they did one of them before. The 2 things, number 1, they took a test that questioned them about their explicit preferences, right? In short, I will say that was a test about whether you are or are not a bigot. And most people were not, right? There were some that were, but most people were not. And then they took the implicit association test, the one that I showed you the pictures of, the computerized test that measures your association, your quick, or the time it takes you to associate photographs with words in order to measure your implicit biases. So we had these 2 sets of data. We had the implicit association, your implicit bias test, your explicit associations, and then we also had the decisions that the physicians made about treating these patients who had a presentation of coronary artery disease. Now, we know that the treatment of choice, because the scripts were the same, we know the treatment of choice was thrombolysis, right? And we know that not to give thrombolysis was an inferior treatment choice. That's one of the reasons that cardiac disease was so good for this study design, because there was a clear right and wrong answer, right, given the script. And so what did we find? You can't read all of these little lines, but here's what the important things that they are. There are 4 different sets of graphs, right? 3 of them are of implicit attitudes that the physicians had about whether the patients were good or bad, whether they were cooperative or not, right? Whether they were nice or not. General cooperative was their niceness. But the important one is on the far right-hand corner. It's the composite, right, of the relationship between the level of implicit bias, low to high on the x-axis, and the decision to give the treatment of choice thrombolysis based on their implicit biases. And what do you see? If one line is white and one line is black, the first thing you see is that they're going in the opposite direction, right? The second thing that you note is the direction based on whether the patients are white or black, right? And so the association that Alexander Green showed is that as the implicit association test showed a higher level of pro-white, anti-black bias, the likelihood that a physician in this participant study would give the recommended and preferred treatment to Black patients decreased, while the likelihood that physicians in this group would give the treatment of choice to white patients increased, right? So they went in the opposite direction. That's bad news, guys. But there's also good news in this study. And it's important good news, because of the some 287 physicians in the study, 60 were told that it was indeed a study about race and its relationship to treatment. Those physicians knew that they were being tested, queried, and studied about race. And the outcome was the exact opposite. In other words, they were able to change their treatment decision directions simply by noting that their biases were being tested. Now, this goes to a body of material that I'm not going to have a chance to talk about tonight, but that is essential and really important to my ultimate argument that we ought to do something about implicit bias, right? It goes to the fact that implicit associations are automatic but not inevitable. I need to say that again, because as a lawyer, we only can hold people accountable for the kinds of things that they can do something about, right? That's what justice is, right? And the fact that we have evidence that implicit biases are malleable, that they can be controlled, that they can be changed, and in fact, that the discrimination that results from implicit bias is under the control of the actor, despite the fact that it's automatic, despite the fact that it's unintentional, means that we can hold people, indeed groups of people, responsible for doing something about the harms that they cause if indeed they do cause harms, right? So the next takeaway message I would like to suggest is that we, each of us, can do something to change our implicit biases and the harms that they cause. Because, in fact, the real beauty of the study design of the Green study is that we know that there was a clear harm, right? We know that those patients who did not get thrombolysis were patients who were harmed by getting inferior medical treatment. And so we can do something about it is the next takeaway. The results from the study, you see the site there, are in red. We could spend some more time on it, but the important takeaway I've already pointed out, I want to point out one other very important one. Implicit and explicit associations work in the opposite direction, right? So as I said in this study, the explicit study, the survey of explicit preferences showed very few people who were biased, prejudiced, bigoted people. The fact still remained that their implicit associations had more control over their treatment decisions. The second set of studies is by a woman named Michelle Van Ryan, and she does a lot of study about perceptions that occur before the clinical encounter. That is, what do physicians think about patients implicitly before they actually encounter them? So Michelle Van Ryan's studies, she's got several, but I'm citing 2 or 3 here for your consideration. She tapes clinical encounters, so does the third study researcher. She tapes clinical encounters and then codes the audio tapes and the videotapes, right? And then she interviews before and after to see if she can in some way discern patterns of thought, expectations, perceptions that physicians have before they encounter patients. This is what she's found. That patients who are from minority groups, whether the physician is from a majority or minority race, if they're American, right? And if you want to get into a deep dive, we can talk about the reasons why African American, Latino, Asian, and white physicians have an anti-Black, pro-white bias at about the same rate. And only changing their gender really changes that rate. Women are less biased than men. Sorry, guys. I will also tell you that of the specialties, what we know so far is that pediatricians and family practice docs are by a small degree, some of the least biased physicians when it comes to pro-white, anti-black biases. We don't know as much about Latino biases. But what Michelle Van Ryan found was that going into, before the clinical encounter, physicians are influenced by their views that patients who are of minority background are more likely to over-report their discomfort. They're more likely not to participate in rehabilitation. They're less likely to have the kind of support, resources, or desire to comply. These are just perceptions and ideas, right? Now, Michelle Van Ryan's studies have been recently validated. Does anybody know about the University of Virginia study of medical students? It was released about 6 months ago. Quite a furor at Virginia, maybe a little longer ago. But the study was of medical students at the University of Virginia, and their perceptions, again, same issue that Michelle Van Ryan is studying, of patients' threshold for pain by race, right? And the study revealed that students in medical school currently, your age, my age, well, your age more than my age, right, are currently perceiving black patients as more tolerant of pain than white patients. But what was really interesting was the reasons that they gave. Black people have skin that is thicker than white people. Black people have blood that clots differently from white people, right? These are perceptions, but you can see how these perceptions would influence the amount of pain care or treatment that a physician would give, right? Now, the hard thing is that Virginia had at first the wrong reaction, right? The right reaction to this data is, we've got to educate people better, right? That's the right reaction. The wrong reaction is, don't call me a racist, right? So that's why I started this talk by saying, we got to have the race talk, fellas. We got to have the race talk, but we don't have to have it accusing one another or being defensive about the problem of being a racist. So another Michelle Van Ryan, I won't linger on this, but because you get the idea. This was a study of just black and white patients, and physicians describe before they meet their patients, black patients as more likely to abuse drugs than white patients. That is just empirically untrue, right? That is just empirically untrue. Yet, people who are very well educated have the concept and the idea. What is that going to mean? How is that going to influence the way that those physicians respond to patients of color versus patients who are not minority group patients? Generally less intelligent. Now, let me say one thing about this one. There is a kind of study that I'm not talking a lot about here that associates implicit bias with statistical interpretation, right? So it's called statistical discrimination. Ann McGuire and Thomas McGinnis study it really in depth. But here's the thing about statistical discrimination. It's really fascinating to me because it takes information that is actually true. It is objectively true that you can read in the Wall Street Journal that there is an achievement gap in terms of educational outcomes between black and white people in this country, right? That is a true piece of data. Statistical discrimination takes a piece of true data and misapplies it, misinterprets it with respect to the individual patient that's before you, right? So that creates a perception, right, that your patient is less intelligent. You don't know whether he or she is or is not, but your bias assumes that they are based on data that's actually true but may not be true for that individual. That's statistical discrimination. That's the way that implicit bias can influence the interpretation of otherwise objectively true data and harm a patient with such a perception as Michelle Van Ryan has found here. More of the same, a study that she did using a scale of 1 to 7 showed again patients of color considered less intelligent, lacking self-control, less well-educated, less independent, and so forth. In any event, you see that these studies associate biases with perceptions that physicians have that will ultimately affect their treatment. Let me do the third set of studies, and then I'll be done with giving you examples. Lisa Cooper is a researcher at Johns Hopkins. She too does videotaping and audio taping of physician and patient encounters, and then she codes them for the communication relationship between the patient and the physician, right? Fascinating, because what she has found is that patients have biases too. It seems so obvious, right? For me, that's the most elegant type of research. It seemed obvious. Why didn't we think of that? But she says when she looks at the length of the clinical encounter, that physicians who have high pro-white, high pro-white, anti-black biases, the length of the encounter is longer for whites than it is for non-whites. The body language and eye contact is closer for white patients than it is for non-white patients, right? The verbal dominance, meaning the opportunity for patients to participate in conversation, to ask questions, and to speak their particular history or contribution to the conversation, less for black patients and patients of color than it is for black patients. She has coded these, right? But here's the contribution I'd like to suggest that my book makes also, and that is to realize that the communication between patient and physician is a feedback loop of implicit bias, right? Because patients, like physicians, are biased also. We all live in, grow in, and develop our social knowledge in the same setting, right? So let's think about it. You're my doctor, right? You're white, I'm your patient. I notice when I walk into the clinical encounter that you kind of look uncomfortable, you're shifting your chair, you sit back and you hold your arms like this. How do I interpret that? He's a racist, right? I have a bias because remember, I got in a lift cab and the guy tried to hijack me and he looks a lot like him, right? So even though I think of myself as I'm giving a now social justice speech, right? Yet I can tell you I am biased. And so when he folds his arms and he asks me to tell me about himself, I'm not telling him too much because I don't trust him. I don't like him, and I'm not telling him my business. So he's only going to have half a deck to work with when he tries to treat me, right? And so then he looks at me and he realizes I'm not forthcoming, and so I'm confirming that I'm not cooperative, his biases. I'm confirming that I'm pretty unintelligent. He doesn't know I have only my defense left to give, right? And he thinks I'm not that smart. And so he starts taking over the conversation. And what do I think? I think he's a racist, right? And so I have even less to tell him, and here's the real rub, and I confirm this with qualitative interviews, I'm not going back, right? When he tells me, okay, Dayna, here's your problem. You're going to need to take 3 of these, and I want you to exercise, and I walk out and I throw the piece of paper. I'm like, I am not going back to him. Or if I'm not that upset, my level of satisfaction with that encounter is pretty low, right? Because we fed off of each other. We both retrieved our social knowledge. We both interacted in a way that reinforced the kinds of implicit associations that we had about each other, and my health is ultimately not helped and possibly harmed, right? So I've told you about implicit biases in 3 stages of the clinical encounter: before, during, and after. I've told you about some of the studies that I look at. If you're interested, I have 6 mechanisms. I've only talked about 3 in this short discussion. But the contribution I'd like to make, and what I'd like to leave you with, is that patients' race and ethnicity goes through 6 different mechanisms at least that we've seen and been able to document in the literature in order to ultimately produce racially and ethnically disparate health outcomes, right? So the question, remember, if you recall when I said, We had this wonderful study from the Institute of Medicine, now renamed the National Academy of Medicine. They knew that bias did something to contribute to health disparities, but weren't sure about the mechanisms. I'd like to suggest that the literature makes clear that there are at least 6 mechanisms, and that those mechanisms are contributing to implicit biases. The last, I've got these takeaway messages out of order, numbered wrongly, but the impact of unconscious and implicit bias, ethnically and racially, is as harmful to health as racism is, right? So if my 6 mechanisms really do change the quality of care, the way I'm suggesting that they are, one of the reasons that we see differences in death rates for all of the leading causes of death virtually, some are changing, right? One of the reasons is because of implicit bias. That's actually takeaway message number 4. How big a deal is it? I think it's a huge deal. Thomas Levis estimated using standard measures of life expectancy that every year 84,000 people of color die because of health disparities. And he estimated, along with the 16th Surgeon General of the United States, that approximately $1.2 trillion are lost in lost productivity, higher healthcare costs over a 3-year period because of health disparities. How am I doing on time? Okay. If it was only the healthcare setting, it would be a problem that we could consider formidable. I want to spend the last part, big problem. I want to spend the last part of my time talking about the long-term systemic impact of implicit bias. And here, I will tell you, this is the direction of my next writing project, right? So I'm trying some things out on you. I'd be interested in your feedback. So as you heard in the introduction, I was in Debbie Stabenow's office as a fellow on her health policy staff in January of 16 when the Flint water crisis was declared. And I have a short line here in case anybody's not familiar with how things progressed to deliver water that was filthy in Flint, Michigan, and how the government of the United States of America, the EPA, and the government of the state of Michigan, the Michigan Department of Environment, delivered this as water for people to drink, cook with, and wash with, right? So the demographic in Michigan is important, in Flint, Michigan is important, right? Because in Flint, Michigan, 37.4% of people are white and 56.6% of people are black. And in Flint, Michigan, the median household income is roughly, not quite, but roughly half of what the United States as a whole is, right? Flint is black and poor, predominantly black and poor. That matters to the story because racism is what this picture depicts, right? You have no doubt in your mind that the reason this sign was put up in 1942 was because the people who wrote it intentionally, deliberately did not want people of color in their neighborhoods. That's racism, right? And that's what we were dealing with. And maybe we're still dealing with, no, maybe we are still dealing with it in some ways today. That's not the same as what it looks like to have housing discrimination in Flint, Michigan today, right? These are the houses, this is an example, of the houses in the black part of Flint, right? That's a sick house. That's a house with lead in it. That's a house with mold in it. And that's a house, if you send me home with an albuterol inhaler, you might as well have sent me home with a teddy bear. because it's not going to be able to beat what's happening in that house where my health is concerned. Discrimination plays a part in putting the people of Flint in that kind of housing. What I'm showing you here is a redlining map that is used by lenders to describe and define the neighborhoods where they will lend money for homes and where they won't lend monies for homes, right? This is a form of discrimination that leads to housing segregation, that leads to the kind of health outcomes that we see beyond the water in Flint. Housing is a social determinant of health, and I hypothesize that housing is infected with implicit bias as well as medical care. Some of the data that we have about housing discrimination talks about the fact that if I go to buy a house in Flint and you go to buy a house in Flint, I'm going to see 17% fewer houses than you will. If I go to rent an apartment in Flint and you go to rent an apartment in Flint, you're going to see 11% more apartments than I will, right? So this is the type of implicit bias. It won't be because the realtor doesn't want to sell you an apartment or sell me a house, right? But it is a bias that is structural and will impact the housing patterns in Flint. Try education. This is what racism looks like in education, right? This was 1954 when Ruby Bridges tried to go to the high school in Arkansas. That's what it used to look like. In Flint, Michigan, here's what race segregation looks like today. Out of 15 public schools in Flint, Michigan, 8 of them have 80% or more African American population, right? It's like Brown versus Board of Education never happened in Flint. Half the schools are fully segregated, 80% or more. And in those schools, you have discriminatory grading, tracking, disciplinary disparities, right? Blue circle is the amount of out-of-school suspensions for black boys compared to black girls, white boys, white girls, right? Last one. These are social determinants of health. Housing is a social determinant of health. Education is a social determinant of health. Food security is a social determinant of health. This is what food discrimination used to look like in 1963. I try to sit at a counter, I want to get a hamburger, I get ketchup spilled on me, right? That is not what it looks like in Flint today. Instead, in the city of Flint, on the day that the state of emergency was declared, there was not a single chain supermarket in the city of Flint, Michigan. This map just shows that the last two, which were Mayo and Kroger, left for economic reasons, right? So it's not explicit racism. They didn't get up and say, we don't want to serve the city because it's 56% black. That's not what they said, right? But ultimately, what was the case was that I can't buy fresh fruits and fresh vegetables in Flint, right? Okay, so the social determinants of health make it so that the governor of Flint could look at the composite picture and say sincerely and believe sincerely this had nothing to do with race, right? Because all that we have talked about with respect to race is racism, and he's convinced that he's not a racist. I'm convinced he's not a racist. Does that change the fact that the social determinants of health led to people drinking that kind of water, being exposed to lead that will last them a lifetime? No, it doesn't change it, right? So I suggest that the long-term impact is severe enough that we really have to do something about it. Here's the last part of my talk. What can we do about it? I have to say that the solutions are systemic as well as individual, right? And we tend to talk about the individual ones with respect to implicit bias. That's another part of the conversation we can have later. Organizations can change their internal culture. That is to make a priority that we no longer will be complicit in, accepting of, tolerant of the implicit biases that result in harms. I'm talking now specifically about healthcare organizations, hospitals, clinics, health plans. They can make a cultural commitment not to any longer tolerate implicit bias because it's that important. What will it cause them to do? I use the example of HIPAA training, right? There's not a physician in the world that's not scared to death of HIPAA and its privacy laws, right? Why are they scared of them? Are they scared of them because they really believe that privacy is that important? They're scared of them because systemically we've taught institutions to take responsibility for training and implementing a new social norm around privacy. We can do the same with implicit bias. Just as we require HIPAA training, we can require debiasing training. We can talk about what that is if you have interest, right? Just as we require administrative structures to require compliance, reporting, and training, and corrective treatment for HIPAA, we can require it for implicit bias, right? We can take the malleability literature, which is copious, and do the things that it suggests. Counter stereotypes, for example. What are counter stereotypes? It's another way for saying the making sure that there are people of different races and backgrounds in all areas and parts of your organization. Those are some of the ways we can meaningfully engage as organizations. Let me also suggest that there are things we can do individually. The acronym is PAUSE. I've actually stolen it from a guy named Howard Ross, who's brilliantly training physicians about implicit bias. And he trains people to pause because implicit biases flourish in settings where you are short on time and you have to use heuristics to make quick decisions and judgments. Remember, crossing the street safely? Same with the kinds of settings where implicit biases create lots of harm. So pause, pay attention to the fact that they exist, acknowledge that you yourself are susceptible, understand that it's not racism, and therefore you don't have to fear that you are a bad person in order to undertake the steps needed to change and address it, but also understand how destructive they are so that you understand you are responsible for a good reason. Engage with others. One of the reasons we have implicit biases is because we know so little about the quote-unquote other. We live in segregated neighborhoods. We play in segregated sports. We don't spend a lot of time humanizing people of other backgrounds. Watch the other guy's news station. It can be painful, but you also can understand and empathize more about where the other guy is coming from. And that makes it less likely that you will quickly jump to judgment about that guy. Get feedback and data from what your activities are. If I'm not implicitly biased, how come I never have dinner at the table over there? How come I never spend my Saturday with somebody who looks differently than me, right? So do some data analysis on your own activities, and that will influence you about whether your results are biased or not. Avoid your first reactions, change the norm about you. Priming is one of the things that malleability literature shows me it works really well, right? So I sit on a lot of committees that make hiring and admissions decisions. Before I go in, I open an app on my phone that reminds me that I am implicitly biased. Remember the Alexander Green study? I prime myself to remember before I go into a setting where I know my judgments are going to be made, exercising a lot of discretion, and I remember that I could be biased in that decision making. So there are things that you can do, there are things that I could do, and I suggest there are things we all can do. And so my last takeaway message is that attacking race and ethnicity biases begins with each of us, and that we can do something about it. In healthcare particularly, I leave you with the thought of Martin Luther King's statement that the most harmful of all injustices is the injustice that denies equal access to health. So thank you for your time, and I'd be glad to take your questions. Okay, all right, that sounds good.
So we've got time for a few questions. We've got some microphones on both sides that will be brought down to people who want to ask a question.
As you may have noticed, there's a disparity in this audience about, in a sense of age. And I was wondering if any of those biases you mentioned are worse for us elderly people than for younger people here.
There's a great age bias test on Project Implicit.
Well, I was thinking of the various health things you mentioned and which ones.
Oh, so whether the age of the doctor or the age of the patient makes a difference?
The age of the patient.
Yeah, the age of the patient. Yes, it does. Yeah. So we have pretty good evidence that, with the exception of, I don't want to say gerontologists because that's a very small specialty, but with the exception of physicians that deal often with older patients, right? Residents, medical students, we have pretty good evidence that they're biased, anti-age bias. They have an anti-age bias. We don't have as much data about their perceptions. We don't have as much data about their statistical discrimination, but we do have evidence about their treatment biases and the length of time that they're willing to spend with older patients. It's not good. Choose your physician wisely.
Hi, I just want to say thank you for coming. I'm really interested in what you were talking about, deeply concerned about it. I'm studying public policy. I'm a senior at Pitzer. Right now I'm actually in a health measurement and justice class. And this week we were posed this ethical dilemma in class that, if it's okay with you, I'd like to throw back at you because I was really concerned with the way my class approached it.
Okay.
And it's about fair chances. I'm not sure if that's something that people have talked to you about in criticism of the work around implicit bias and countering implicit bias. Essentially, the dilemma was, I guess, so there are 800 urban people and 200 rural people, and there are two different ways of treating them. The first one will save all 800 people that are urban, and the second one will give everyone a fair chance, but only save 500 people. And I'm wondering if you get that kind of response of people saying, like, I could see the narrative be the work that it takes to pause for physicians, to pause and recognize their own implicit bias. That time means that they're not treating as many people, and so they're not saving as many lives. Does that make sense?
I think so. I think that I want to repeat it back to you to make sure that I've got it, because the question is an ethical dilemma, both because it asks you to sacrifice some portion of the population at the expense of another.
Right. So I think the dilemma is in one instance you're saving more lives, but inequitably, and in the other instance you're treating people in an equitable way, but not saving as many lives.
Right. So then the second thing it does is ask you how high a priority do you want to put on equity?
Yeah.
Right?
Exactly.
Yeah, but it does a third thing that really does trouble me, honestly, because both of those other questions are sort of, in my view, garden variety, sort of, ethical dilemmas, and there's no right answer. We could talk about them for a long time. But the third thing that it does is pit rural against urban populations, and I find that troubling, right? Because that's not a zero-sum game, right? And that's a trick. That's an unfair trick, right? We don't get to value one population over another unless the question was asked to make that point, right? We don't get to say, as I think our current political climate does to us, right? It's us against them, and if we take them, it ruins us, right? It's if they get, we don't, right? And we've got to make sure that they don't get, and we've got to make sure that we define them as they, and we put them in a they box, rural, and they are opposed to us, urban, because both of us can't get. That's the part of the problem that sort of gets my hackles up, right? But does it happen in medical practice, in the practice of health, public health, population medicine as well, that you have a value to place on equity, and you have to prioritize that value with respect to other values, such as prioritizing who gets saved or how many get saved, right? Do you have to make that judgment? Yes, you do. You have to make that judgment. Those are hard decisions, and we have to make them every day. I don't doubt that those decisions are also influenced by implicit bias, right? Especially since you made the question for me to be biased, right? If I'm from the farm, I'm going to like the rural guys, and I'm going to want to save them. If I'm from the South Bronx, I'm going to like the people for whom the urban background is describing them, right? It would be a reason to pause, right? It'd be a reason to pause and recognize that the question requires me to make the kind of judgment where my implicit biases are going to rage, right? They're going to rage. High discretion, high power differentials, right? You've made me God, essentially, in this problem. I get to decide who lives and who doesn't. High power differentials, short time, severe outcome, and I have to make a call. I have to make a call. That's where implicit biases rage, right? So all of the things that I've asked you to do individually, I would say are the way that I reach an ethical decision. And if I trust myself to be equitable when I know that I am biased, I would say that is an unethical outcome. I'm not in charge of who's asking, right?
I was wondering if there are any medical schools that you've worked with that have implemented the anti-implicit bias sort of curriculum. And
yeah, that's a great question. There are a couple of medical schools that are trying. I was at Yale last week, and they have an implicit bias class. It's so cute. Because they're trying so hard. And I think that's really good. But they did call me, right? They did say, what's wrong with this? And I just got to say, well, there is this literature that shows that what you're doing is cute, but it's not quite going to work, right? So there are a lot of people that are trying to do something. Virginia, honestly, is doing. I think once they had their hissy fit about the pain study, they're doing a great job now. Here's what works. Debiasing works when it is structured as a training to change your habits, right? And how long does it take to form a habit? You guys know this, right? It's not about going in for a 2-hour class to tell me what Cinco de Mayo day is, right? That's not going to change your habit, right? You took a long time to learn the social knowledge, and now you need to unlearn the social knowledge. You have to learn how to take in the things that will continue to inform your social knowledge and take control over them and process them differently. Courses that take about a semester tend to work. They also have to include a couple of things, debiasing. They have to include an opportunity to do hard introspection with people of another background. You have to have hard conversations, right? So I have to tell you my life story. I have to tell you the story about my grandmother who got beat up by black guys, right? And that's what makes me afraid. You have to tell me the story. This is what I just heard today. A woman called me today and she said, I raised my kids. She's an African-American woman. Actually, she's not African. She's Black Latina. She raised her kids in a white neighborhood, and she said, my kids went to the playground and they saw vandalism, And they came home and they told me, white kids are really bad. They're violent and they mess up the playground. And because where they went to church was all black kids, right? Or Latino, African. So they were like, the white kids are bad kids. And she said to me, I actually had to deprogram that. I had to deprogram my black kids thinking that white kids were the bad kids, right? And I wish the other mothers had done a good job for my kids as well. But what I'm suggesting to you is biases are habits. They're habitual ways of thinking. I used to be a really bad speeder. I used to speed a lot because I was always late to court. And so you don't have to raise your hand, but I will tell you that if you were in my class, I had to go to a class for a semester, right? It's called the Habitual Offenders Class. And I am no longer a habitual offender. I've been redeemed, right? But it took a semester. It took a long time. I had to visit an emergency room, and I had to go every Saturday morning. It was awful. But I don't want to go back. And so my habits have been changed. Now, am I tempted to speed? Yes. I mean, but I haven't had a speeding ticket since September. I'm not telling you, but I haven't had one for a really long time, right? So habits can change, but debiasing really takes time. It takes also some counter stereotypes, right? So you have to have somebody there who is, I'm going to be very crass about this, because I went to dinner in Virginia last week. The black people can't all be serving you dinner, right? You can't just say that, that's not good enough. So it's a really deliberate process, but it works. And that's the thing that makes me, when I give this talk at a law school, most of the time in the end where I'm talking about nice things that you can do to pause and blah, 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 I'm talking about how to sue people, right? And I'm talking about how to use the law as a solution. But the reason I get to talk about that is because it is in your control, institutionally and individually, to do something about implicit bias.
Okay, there's one other question here. It's, you talked fairly generally about a fairly obvious perception difference that the physician has between blacks and whites. There's another health dimension in this country that's really bad, and that's overweight or obese.
Yes.
And I was wondering whether the breakdown between blacks and whites is different and how they get treated is different.
Yeah, so two things. Yes, there are implicit bias. There's a lot of data about how we're biased against obese people. Yes, and just overweight people, we're biased against them, and physicians are biased against them. So there's that. Here's a limitation, and we didn't get to talk about the science or the social science of implicit bias and measuring it. A limitation of implicit bias is that it does not, the data, is that it doesn't do intersectionality very well, right? So we don't know what it means to be an overweight, gay, black woman and what that does to your implicit bias, the receipt of implicit bias in your treatment, right? We don't know. We also, another limitation of the implicit bias literature, it doesn't do intersectionality, does very well, and it only talks in dualities, right? So we know pro-white, anti-white. We know pro-black, anti-black. But we don't know anything about the nuances, right, of how the relative biases will work. Like your ethical question, right? How do we prioritize equality? How do I prioritize? It's not exactly the same, but how do I prioritize my biases when I'm dealing with people? So there's a lot of limitations in the literature. A third limitation right now is we know most about physicians, almost nothing about nurses, almost nothing about pharmacists, nothing at all about PAs, other clinicians. And I'll tell you somebody I really want to know about. Have you guys ever gone to the dentist and had that person in the front office just tick you off, right? I just don't go back. I want to know about those people. I want to know their role in the healthcare system. I bet your bias has a lot to do with my health outcomes, right? So there's lots of work to do, and that's one of the reasons I like the field, and I thank you for the opportunity to talk with you about it.